Okay, welcome everyone to the Grand Round. There are three of us going to speak for the next 45 minutes or so, and we're going to talk about Cushing's syndrome and give you an update. It's a growing problem, not that it's becoming more common, but it's becoming more and more difficult to diagnose, and we'll explain why. So I'm going to start with a bit of a historical perspective, and then Drs. Wall and Hamid will present some cases, and then we'll have a summary discussion at the end. Okay. So our objectives today are to go through three cases of possible Cushing's syndrome, which is really a difficult diagnosis to get right. We'll talk about the test that we do, one of which includes the midnight sleeping cortisol to make the diagnosis of Cushing's syndrome. To look at the predicted value of these tests, and the Dexamethasone tests have been around since about 1960, and the predicted value used to be quite high, but it's falling, and we'll explain why. And then a lot of you will have learned at medical school about the low and the high dose Dexamethasone test, and we're going to explain why this is a no longer undertaken test by us in 2008. And then how we actually exclude ectopic ACTH, and Dr. Hamid will do a case of this. And the purpose of taking blood from the pituitary gland is not to confirm that that is the source, but to exclude ectopic ACTH. I will give a bit of a history. So I was an SHO at the Hammersmith in 1989, and I had a short period of about a month overlap with a professor of endocrinology called Graham Joplin. And he got me to present a case of Cushing's disease on the staff round at the Hammersmith. And in those days, we talked about how we made the diagnosis with a low and high dose Dexamethasone test. The patient we were talking about was one who was given a yttrium implant some years before, which we no longer do. And in those days, the patients were invited to the staff round at the end of each case, and the professor of medicine would bring them into the room, and the assembled audience would ask them questions. And this patient was so keen to impress that she came in a ball gown, and she talked all about her Cushing's, and it was fascinating. But I'll now give you a bit more background history. So this is from a publication that Graham Joplin made in 1960, okay? And it's the treatment of Cushing's disease in 1960 was to implant gold radioactive seeds into the pituitary gland. And if you look at this case, right, he was 27 years old, and in 1960 he presented with what we now recognize as typical Cushing's, obesity, stretch marks, and then his obviously was quite a large tumor because he then developed a third nerve palsy, and he got worse and worse and worse. And before surgery, he was seen, or before treatment rather, he looked Cushingoid. He had a third and fourth nerve palsy, so quite a big tumor. Now, of course, they didn't have CT or MRI. What they did to find the tumor was an air encephalogram. Now, what that meant was you do a lumbar puncture, you inject air, and then you do a plain X-ray of the skull, and it surrounds the pituitary, and you can see the pituitary gland and how big it is. And then to see the adrenal gland, they would inject oxygen into the abdominal cavity, and they could see the right adrenal was hyperplastic on that. So imaging has moved on a long way. And then the biochemistry, they didn't have an assay for cortisol, so they used 17 ketogenic steroids, which is what 17 kgs stands for. And they were then defining the reference ranges in those days, and he was looking at urine, saying the 17 kgs ketogenic steroids were 25 milligrams. And then there's the beginning of the Dexamethasone test, and they gave 4 milligrams a day, and they said it didn't suppress because it suppressed to only 5 milligrams 24 hours, and normally it falls to less than 1. And you've got here data to be published. This is the new, now we use it a lot, of course, the Dexamethasone test, but this is its first description. And then because they couldn't see the tumor, they just had to almost go blind and put in the 7 seeds of radioactive gold into the pituitary gland. And what happened, they did a biopsy at the same time, and they had features of a tumor, and Crooks hyaline cells are the ones that you see in patients who've got Cushing's. And the progress was very good. The 17 ketogenic steroids fell to 13 from 26, so that's a good fall on the 9th and 10th days. The patient didn't need any HRT, no lack of hormone, because I guess it didn't destroy the whole pituitary gland because it's quite a big tumor. And then at 4 months, it says, features no longer Cushingoid, stree pale, generally fit. So a really good outcome, sticking radioactive implant into the pituitary gland. That was 1960. Now, what was the long-term outcome of this? Well, it was rather good, because 30 years later, this paper came out just before Graham Joplin retired, and it's the long-term follow-up of his patients who were given interstitial irradiation. Now, of course, at that point, they'd moved from gold to yttrium-90, and they basically had 30 years follow-up, and they basically said none of them came to any harm, and they all seemed to do pretty well, and with a high remission rate and no recurrence as yet, and no operative complications, and avoiding HRT in the majority. So that was a good summary. And in fact, since then, because Hammersmith was the only place doing this implant, we follow them up until they all died of old age. And really, we've had no recurrence at all of these problems. So here's a question: why have we stopped doing it? Well, first of all, we can now see the tumor, okay? And first of all, with CT scanning and then MRI scanning. And now, of course, with the 3 Tesla magnets, you can actually see the adenoma. And then when we merge with the Chancross neurosurgical unit, we've got neurosurgeons who are able to see on direct vision the tumor and remove the tumor and leave behind the normal functioning pituitary. So that has been a huge improvement for all these patients in terms of outcome. So that's now a regular occurrence on our unit. Anyway, I'm going to hand over now to Dr. Walls, who's going to give us a couple of cases. So if you'd like to share your screen, I think I might need to stop sharing. And I think I need to, make you a co-host. I'll do the same for Dr. Hamid in a minute as well. Okay, you should be able to share now.
Thank you. I think I'm sharing.
Yeah, we can see time.
I'll just remove this. Okay, so thank you, Prof. Miran, for a very interesting historical perspective. So I'm going to present 2 interesting patients, both similar in some ways, but with distinct differences. So the first is a 41-year-old lady who was overweight and depressed. And in 2002, she had a miscarriage, and she found that after that, she was piling on a lot of weight. 3 years later, she was diagnosed as having hypertension, type 2 diabetes, and suffered with severe depression, and she began to lose weight. Then 8 years after that, she fell pregnant, but sadly developed postnatal depression. She also noticed at the time that her hair was falling out, and she'd developed some facial hair, and she'd also begun to gain a lot of weight. In 2014, she put herself onto a low-carb diet and managed to successfully lose lots of weight, but she struggled to keep it off. And in January 2020, she presented to Hillingdon Hospital with weight gain. So at Hillingdon, they were concerned that she may have Cushing's, and so she was investigated. So just to better understand the investigations we do for Cushing's, I'm going to quickly go over the axes. So the hypothalamus produces corticotrophin-releasing hormone. This acts on the pituitary, which produces ACTH. The ACTH, it acts on the adrenals, which produce cortisol. And this is all part of a negative feedback loop. So one of the first things we do is to establish if someone actually has hypercortisolemia. And at Hillingdon, they did a 24-hour urinary cortisol collection and found that this was elevated at 554. The next thing to do is establish whether the cortisol just comes from the adrenals or whether this is ACTH driven. So if there is an adrenal tumor, then the cortisol will be high, and by negative feedback, the ACTH will be suppressed. However, if there is a pituitary tumor, then the ACTH will be high. That will drive the cortisol to be high, and the negative feedback will be fairly ineffective. There is, of course, a third source of ACTH, which can be an ectopic source from a tumor, perhaps a lung tumor or carcinoid. So that ACTH is high, and that acts on the adrenals. The adrenals produce a lot of cortisol. Now that is part of a negative feedback loop, but only on the pituitary. So the pituitary ACTH is suppressed, but on simple blood testing, it's indistinguishable from the ACTH from the tumor. So the next thing we do is we would establish the relationship between the cortisol and the ACTH. And at Hillingdon, they did this, and they found the baseline cortisol to be 337, but the ACTH to be inappropriately high at 84, suggesting that this is ACTH driven. He went on to do what Prof. Miran described, which was the dexamethasone suppression test, which is now very commonplace. So you give exogenous steroid in the form of dexamethasone, and in a normal person, the ACTH will be suppressed and the cortisol will be suppressed. But in this lady, she did not suppress her cortisol, so her cortisol remained elevated at 389, again suggesting a pituitary source of her ACTH drive on cortisol. So back to this lady. So because the pituitary Cushing's was suspected, she went on to have a pituitary MRI. And this is her MRI here. And if I just point out here, this is the large pituitary macroadenoma that she had, which was 1 centimeter in size. So then she was referred to us at Charing Cross to the pituitary MDT. So let's just have a quick review of the situation. So here we have a lady who is overweight, and of course, historically, being overweight could be a sign of having Cushing's, but being overweight can also raise your cortisol levels in the absence of Cushing's. And as we know, being overweight is common. This lady was also depressed, and being depressed can be a sign of Cushing's, but having a mood disturbance or being depressed can also raise your cortisol levels. And having a mood disturbance such as depression is also common. Now, as for pituitary adenomas, radiology studies and autopsy studies show that they are also common. Pituitary Cushing's is incredibly rare, so making this diagnosis amongst many common things is quite tricky. But it's really important for us to be as sure as we can be of the diagnosis, because the treatment is ultimately surgery, and surgery can have a lot of implications. So if we look back now to the signs and symptoms of Cushing's that she may or may not have. So this, in terms of the argument for, she does have weight gain, she's hypertensive, diabetic, she has hair and skin changes, she had a miscarriage, which often happens in Cushing's, it can't maintain a pregnancy, and she's depressed. The signs and symptoms against Cushing's are the fact that intermittently she's really very successful at losing weight. She did eventually have a successful pregnancy, and depression, as we've discussed, is common. So when she was referred to Charing Cross, we felt that clinically she probably did have pituitary Cushing's, but we wanted to be absolutely sure, so we did some more tests. We went on to do a cortisol day curve. So this is where you just take a blood sample for cortisol at different times throughout the day. And you'd normally expect the cortisol levels to decline off towards the end of the day. Here you can see hers are fairly static in the sort of late 300, 400 range throughout the day. It doesn't tail off. She also had a late night salivary cortisol. So the patient takes home some tubes and then spits in them late at night. And normally the cortisol levels would be low in a normal person late at night, but hers were high. And these tests showed that she had a loss of her diurnal rhythm, which would be typical of Cushing's. So with a bit of a COVID delay, in August 2020, we did our final test, which was inferior Petrosal sinus sampling. Now, a quick word about IPSS. So this is the pituitary gland. It drains into 2 veins, which join to the inferior vena cava and then into the femoral veins. So in IPSS, a radiologist will pass 2 catheters through the femoral veins, feed them up through the IVC and into these 2 veins that drain the pituitary. Blood is then taken for peripheral ACTH levels and also for ACTH levels from the veins draining from the pituitary. And the important thing about IPSS is to ask a very clear and accurate question at the beginning. And the clear and accurate question is this ectopic Cushing's? And then you look at the peripheral ACTH levels and make sure that they are lower than the ACTH levels draining from the pituitary. And then you can say that this is not ectopic Cushing's. If you ask the wrong question, which is this pituitary Cushing's, then you can end up labeling a normal person as having pituitary Cushing's. So let's have a look at her results. So you can look at this table, there's time from -5 to 10 minutes. And so that's the time that the blood's taken. It's the left vein draining the pituitary, the right vein draining the pituitary, and the peripheral vein. So the first thing to look at is the peripheral ACTH. And you can see here that it is not higher than either the left or the right veins draining the pituitary. So in answer to, is this ectopic Cushing's? The answer is it is not ectopic Cushing's. And so that is our interpretation of the IPSS. You will notice here that the right vein draining the pituitary has incredibly high levels of ACTH. Now, this is interesting, but it is not diagnostic, so it's just a point of interest. Okay, so after having had inferior IPSS, we felt that this was not ectopic Cushing's and therefore likely pituitary Cushing's based on the other results. So a few weeks later, she had transsphenoidal surgery, and the proof is always in the histology, and the histology showed a corticotroph adenoma confirming pituitary Cushing's. Now, we saw her recently in clinic, and she feels like a new woman. She feels a lot better, she's lost weight, her skin and hair have improved. Now we're going to compare and contrast this to another lady. She is a 34-year-old lady who's overweight. And in 2016, she presented to her GP feeling tired. Thyroid function was performed and she was found to have a high TSH. Now cortisol was also performed at the time. It's unclear why, but maybe they were looking for Addison's and therefore looking for low cortisol. But when the result came back, it was 700, which is on the high side. Of note, she was also on the oral contraceptive pill, which can increase the cortisol binding proteins, which can give you the appearance of high cortisol levels. As a consequence of this, she was referred in 2017 to another hospital, and there she was investigated for Cushing's. So she had an overnight dexamethasone suppression test, which didn't suppress because it was high at 780, a low-dose dexamethasone suppression test, which was abnormal at 550, and all the while she was probably on the oral contraceptive pill. She went on to have a pituitary MRI, which showed a left-sided abnormality, and she also had IPSS. So again, we look at the peripheral ACTH levels here and ask the question, is this ectopic Cushing's? And because the levels are not higher than the veins draining the pituitary, we can say this is not ectopic Cushing's. But note was probably made also to this level of 731. But really, this can happen in normal people and should be ignored. She went on to have transsphenoidal pituitary surgery. In fact, she had 2 bouts of that within 5 days. And the histology showed normal anterior pituitary gland tissue. So when she presented to us in January 2018, she came for a second opinion. She was on 4 different types of hormone replacement, and she wanted to start a family, and she was asking whether she needed all this medication. So we spent a large part of 2018 performing numerous investigations. So we did a cortisol day curve. We decided that she might not need her steroid, but then when we stopped the steroid, she lost her periods, which is unhelpful because she was trying to start a family. So we restarted at a low dose of 1 milligram of prednisolone. She had blood tests for thyroid function, which showed she still needed her thyroxine. And she had a gonadotrophin releasing hormone test to look at her fertility axis. And it actually showed that her LH and FSH were probably okay, but they were not sufficiently stimulating estradiol, and therefore she needed HRT. But she was desperate to come off the tablets, and so we started to test her regularly and slowly wean her off some of her tablets. But in 2019, in March, she became pregnant. And then she went through a high-risk, extensively monitored pregnancy because she was believed to be hypopit. And in October 2019, she delivered a healthy baby. We've seen her in 2020, and we've continued the weaning, and she's been successfully weaned off everything with good pituitary recovery, all bar the thyroxine, which she remains on. So really, this lady probably didn't have pituitary Cushing's, and if we go back in time and look at the core signs and symptoms, we can see that yes, she was overweight, but she presented with tiredness and really didn't have any of the convincing clinical signs or symptoms of Cushing's. But when you start testing for Cushing's in these people, you end up on this relentless trajectory, and it's very difficult to unsee the positive results that you've generated. So this really is it's a very easy situation to be in, and it can happen to anyone at any hospital, because what we're dealing with here is very common conditions in the population, and throwing that into the mix with a bit of trigger happy testing, which we're all guilty of this. So a few false positives, a few negatives, maybe a few true positives, but rare. And then you end up in a very confusing situation. But it's really important to be certain of a diagnosis of Cushing's, because the treatment is surgery. And as we've shown, the implications of surgery and the long-lasting effects can be quite significant. So to conclude, Cushing's is most definitely a problem, and we'd never want anyone to miss a diagnosis of Cushing's, but establishing what is not Cushing's is increasingly becoming a growing problem. Okay, thanks, Prof.
Okay, thank you very much. I'll just share my screen again. Okay, I hope you can hear me. So the issue really is important, because the story you just heard is not uncommon, and the second patient is extremely common in centers that are not very well geared up to excluding or confirming the Cushing's diagnosis, because it's very easy to fall into the trap as has happened with that second patient. And in fact, quite a lot of our second opinions from other places have, this is not a rare situation. And the problem is that Cushing's is very rare, but everyone's heard of it. So it's about, as you heard, 30 per million inhabitants. And so what we need is a test which is very sensitive to pick up all the cases that have got Cushing's, but we need a specific test. And the problem is, it's a rare disease, and there's a trade-off between sensitivity and specificity that mean that we get a number of false positives. Okay, so that is a big problem. So we have a number of tests that we try and do, and I'm keen to make sure, as you've heard, that we have got real Cushing's, because we always present the real Cushing's, but we need to talk more about the ones who haven't got Cushing's and what to do about them. So we have a number of tests, and they're not new. The urine-free cortisol, a midnight sleeping cortisol is something that's quite interesting and has had its phase of interest. The late night salivary cortisol is one of the better tests into the specificity and sensitivity, but no test is 100%. And then there's the Dexamethasone test that we've used since about 1960 with moving targets. So first of all these tests have their problems. And the first one is the urine-free cortisol. Basically, it depends on the free cortisol, which is a 10% of the total cortisol. And it's unaffected by things like the pill, because it's the free cortisol. And the problem is blood cortisol is looking at the total cortisol, which goes up, as in the second case, if you're on the pill. So you need to, rule number one, stop the pill before you do the blood test, but not for the urine tests. We have got people that are falsely high level when they drink a lot of water, and false negatives happen if you have renal impairment. And the real problem is that it's not easy to do a complete 24-hour collection. We say it is, but people forget, miss out bits. Sometimes they collect the morning sample twice. So you can get either too much or not enough urine, and therefore false positives and false negatives. So the other thing is looking at the diurnal rhythm. So this is the typical average. And if you do lots of these people and they have a standard environment, which is dark at night and light by day, and they sleep from 10 p.m. to 8 a.m., then you get this kind of cortisol pattern with a rise early in the morning before you wake up. It peaks at about actually 8 a.m. rather than 9 a.m. And then the level drifts down through the day. And at midnight, it's really low if you're asleep. Okay, if you're asleep and you're not stressed out by someone taking blood from you. So it's got to be done through a catheter while you're asleep. And then in the early hours, it rises again. If, on the other hand, you have Cushing's of any sort, the cortisol doesn't budge. You lose that diurnal rhythm. So measuring it in the morning is not going to distinguish Cushing's from normal, but a midnight cortisol will be very high compared to normal. So that is the time to measure it, the midnight sleeping cortisol. However, you need to be very careful when you see the numbers like 100%. So this came out in 1995, and it's a bit misleading, but it says a single sleeping midnight cortisol has 100% sensitivity for diagnosing Cushing syndrome. Okay, and this is the data. These are all their patients in their center who had Cushing's disease, that's pituitary, or ectopic ACTH, or unknown source, okay, and they measure the cortisol, and all of them at midnight had a level above 50, okay, when they were asleep. And then they got 20 controls, healthy volunteers, did the same thing and showed they were all less than 50. So that looks really good. However, it's a midnight cortisol when they're sleeping, but this is the thing, right? It's a retrospective analysis. You cannot talk about specificity when you go backwards, okay? This is a very misleading paper because it says between 1970 and 94, they look backwards. Now, what do you think happened? The patients who had a cortisol of less than 50, who actually had pituitary Cushing, well, they were discharged. They were told there's nothing wrong with you. So they're not here. So retrospective studies are very misleading, and don't be fooled by this kind of 100% specificity and sensitivity, because it's wrong. They've taken some other controls. This is not prospective. You've got to do the studies prospectively if you want to say something is specific or sensitive. The Americans copied it, did the same study, slightly different. They did single midnight cortisol in non-sleeping people to distinguish Cushing's from pseudo-Cushing, and published this paper. And essentially, the top black line is Cushing's syndrome, and this line here is pseudo-Cushing syndrome, in other words, simple obesity. And this is the time of day, and you can see that if you've got Cushing's, your cortisol stays high all the time. But if you haven't, it falls through the day. This is 8 a.m. and then by midnight or 11, it falls to about 100 because they're not sleeping. So they set a new cutoff of 108 nanomoles per 4. They use American units, micrograms, as a cutoff to say if you fall basically at night, even if you're awake, then you haven't got Cushing's probably. But they're not sleeping in this study, and therefore the cutoffs were slightly different. And then there were individual data, and they said if you set the cutoff at 200 nanomoles, then you have a test that's 100% specific. In other words, all normal people are correctly identified as normal. But in the Cushing's group, you're not totally sensitive because you're missing these people down here. So it's very hard to find a test that is 100% specific and 100% sensitive, despite everyone wanting to do that. Now, I'll just give you a bit of baseline statistics to explain what the problem that we have. Okay, so this is the pattern of referral at Charing Cross. So we are a tertiary referral centre. So what happens is patients with suspected Cushing's might go to other hospitals like Hillingdon or Westmead or George's, and they have some tests, and many of them are told you're normal and discharged. But if they have an abnormal test, they then get referred here for pituitary surgery, because this is the centre for surgery, and then we can just rescreen and be absolutely sure, as Dr. Walls described. And so we do it again, and here is 150 patients, okay, of which 100 turned out to be normal and 50 turned out to have Cushing's. So there's the cutoff at 50, and the Cushing's patients are above that point and the normals are below. But there's a bit of an overlap here, so some normals and some Cushing's patients overlap, okay? So if you set your cutoff at 55 nanomoles for a midnight sleeping cortisol, okay, then there will be some red people here, false negative. They have got Cushing's, but they're told they are normal, okay? Now this is here where 1 in 3 referrals have got Cushing's. That's the prevalence in our population, okay? 50 in 150, or 1 in 3. So in that situation, we had 48 patients with Cushing's, okay, 2 of whom were told they were normal. And so our sensitivity is 96%, which is not bad, but we're going to miss these 2 people. But the nice thing is the specificity is 100% because all of the negative people were correctly identified as not having Cushing's. So we have 100% predictive value also. So the 48 people, so if you have a positive test, then you definitely have Cushing's in this scenario, okay? And if you have a negative result, then we miss a couple of people. And so this, the negative predictive value is 100 over 102, which is 98%. So that's 55. But supposing we say, right, we don't want to do that. We must catch everyone. Let's move the target down to 46 nanomoles per liter, where we will then catch every single Cushing's patients. We will label a few normal people with Cushing's, but maybe we can do some more tests and exclude them. So let's look at that. 50 people with Cushing's, 100 haven't. All of the red Cushing's people are labeled correctly as Cushing's, no false negatives, completely sensitive. However, it's not totally specific because of the 100 normal people, 2 are told they've got a high cortisol, and therefore the specificity is 98%. The predictive value of a positive test is 50 out of 52, and therefore it's 96% of your patients with Cushing's. With the test that's positive, will be told they have Cushing's. Now, this, as I'm trying to emphasize, is here where 1 in 3 people have got referred, turn out to have Cushing's. But supposing we start looking at all obese people, supposing the prevalence, I mean, you know, it's only 30 per million. So let's take just obese people because we think that obesity is a feature. Now, the problem is if it's 1 in 10,000, to get 50 people with Cushing's, we need 500,000 normal people. And that would be the referral pattern. We take 500,000 normal people, and 50 Cushing's patients and try and do this test. Now look what happens. The problem is the curve on this side goes up to the ceiling, comes back down the other side. It goes up for miles. So there's a lot of false positives. And if you look at this, it's very specific, it's very sensitive, but there are a lot of false positives. So here's 50 Cushing's patients, 100% sensitive. Here's 500,000 normal people, okay? Now there are 9,000 false positives, but 489 true negatives, and so it's still really specific. So that's going to fool you because the predictive value of a positive test is really poor. It's 50 in 10,000. So if you have a positive test, you're more likely to not have Cushing's than have Cushing's. And this is what is happening in a lot of surrounding hospitals, a lot of false positives at the edge of that curve. So it is dangerous to do screening tests in just obese people without several features of Cushing syndrome. Then this paper came out in 1998 that was a new test because they said the Brits don't know how they're doing it. This is a new test, the corticotropin releasing hormone stimulation following Dexamethasone. So they said, let's give some Dexamethasone, and then we'll give CRH and stimulate any tumorous cells to make cortisol. And they tried all kinds of stats with it, okay? And they set several different criteria. This is one of them, comparing Cushing's with pseudo-Cushing's. And they just looked for a cutoff that would distinguish the black dots, and they couldn't find one. You set the cutoff there, you have a load of missed cases or a load of overdiagnosed patients. And then they came across this. Now, this was what they did lots of tests. So that's the first dangerous thing. And here you are. When you give them Dexamethasone, the normal people suppress, and the Cushing's mostly don't. But unfortunately, these 4 people were labeled normal. So the test, the old-fashioned Dexamethasone test that we've used for years, would miss some of them. But then they said, let's give these people after the Dex a bit of CRH, and they measured the cortisol and ACTH at every time point and found one time point where it seemed to be quite good. In other words, all the normals were less than 38 and all the Cushing's patients were more than 38. So you give Dexamethasone and then CRH. And in this study, they said, isn't this great? We've found the holy grail, 100% sensitive, 100% specific, totally diagnostically accurate, with 100% PPV and 100% NPV, because there's the line. You set the line at 38 and you pick it up. So they said, this is the test. We will never get it wrong in the future, okay, to high acclaim. However, we repeated that paper, that study. We did the whole thing. It took us several years because you need to pick up a lot of patients and put them through both tests. And so we did that. And to summarize what we found, is it's not 100%, because first of all, there were some people where it was excluded, but there you are, considered Cushing with a high level of cortisol after the combined test. And worst of all, there were some with discordant results. And therefore, our conclusion was really that adding CRH to the LDDFT does not improve the accuracy of the test, and we're back at the drawing board. So we shouldn't screen, okay? Screening for Cushing's is a bad thing to do, even with obesity, because if you're obese, and the prevalence of obesity is going up. You see, this is the prevalence of obesity in the US in 1986 when this test was popularly used to diagnose Cushing's. And if you're obese, then you might have Cushing's. And notice there are no red states here. Okay, so everything's less than 19%. Let's miss out the 20 years and cut 20 years forward. Not only have we got new colors, I mean, there's 3 new colors, okay, because 20% wasn't enough. So the prevalence of obesity is absolutely rocketed. At the time, we're saying obesity is a feature of Cushing's disease. Not anymore. Also, diabetes is going up in prevalence. And so our problem is that we're seeing more and more obese, normal people who think they've got Cushing's. And we're no better. We want to keep up with the Americans and also push up our prevalence of obesity in the same way. And so now, since 2006, this is comparing Cushing's disease with normal people. There is no difference in the prevalence of either being overweight or obese. So obesity is no longer a feature that could point you to Cushing's because it's so common in the normal population. If you have a number of things, including high blood pressure or diabetes or both and depression, it might start to point you towards it. But these are all really common conditions, and we need to pick out the rare patient with Cushing's disease. So that is getting more and more difficult because the prevalence of obesity is rising. Referrals contain more obese normal people, and therefore the prior probability of Cushing's disease is falling with time. So this paper we discussed a minute ago, the midnight sleeping cortisol, was widely used, and it's no longer very specific, partly because some patients aren't asleep at midnight. And the other problem is that they're all reading the literature. It's also not very practical because you need to admit people to hospital and they need to be asleep at midnight, and they need to not know that they're going to have a blood test, because if they know they're having a blood test, they're all stressed and their cortisol doesn't fall in normal people. So you can't do it as an outpatient. And I say that because now we're doing our COVID online referrals and phoning up patients. And this is a referral that was in the pathway, and I read it, and it says, patient with weight gain, mood disturbance, and hirsutism, with a high BMI and a high blood pressure. But it did say there's no stretch marks, no bruising, and no muscle weakness. And the GP wrote, does she have Cushing's syndrome? And I'm highlighting this because on the next page it said her midnight cortisol was raised at 600 nanomoles per litre. So I thought I must ring this patient because it's a phone interview anyway. And I phoned her up and I said, I see that you've had a midnight cortisol. How did that happen, and how was it done? And she said, I've read your papers, and I've read all the papers on this, and I know I need a midnight cortisol because it's 100% sensitive, and mine is high. So I rang my private GP up, and I drove to his house at midnight and did a midnight cortisol. Now that is obviously misleading because she wasn't asleep. So the problem is there is no single perfect test for Cushing's. There's no easy way of getting it right. And we need a lot of screening tests. And because the pre-test probability, that is your assessment clinically, examining the patient, is the best marker of getting it right. And if they only have obesity, it's not a good marker. They need to be weak, because obese patients are strong. They can climb stairs because their muscles are carrying this large weight around. But if there's discordance between your suspicion and the screen test result, you wait and you reassess. You don't rush into IPSS or surgery. That's a really important point. So this is from our last letter to various journals, and the point really is that since 50 years ago, since Liddell described the low-dose expression test, a truly accurate diagnostic test for Cushing syndrome has yet to be described, and we're still there. So if a patient has many features of Cushing syndrome, and several tests confirm it, and you think this is definitely Cushing's, I'm really convinced clinically, then we will move on to the next step, which is finding out where it is. Is it pituitary? Is it ectopic? Or is it adrenal? And I'm going to ask Dr. Hamid to tell us about a case to look at how we investigate this. We used to do a high-dose Dexamethasone test. I've got one more thing to say before I let Dr. Hamid talk, and that is, we used to say that high-dose Dexamethasone will suppress the cortisol in patients with pituitary Cushing's, but not ectopic, and therefore that was a test we used to do to say, is it pituitary or ectopic? However, that has also changed because I'll show you the data from this study. This is a paper that changed my practice. This left-hand column is ectopic ACTH syndrome, and this is the Cushing's disease. So lung cancer patients, or tumor or carcinoid, or pituitary Cushing's. And you can see that urine-free cortisol doesn't distinguish them. They've all got Cushing's, okay? And look at plasma ACTH. They're higher in the ectopic patients, but there still is quite an overlap. So you can't say if it's pituitary or ectopic. So what you then do is you give the patient high-dose Dexamethasone, and the original textbook said that Cushing's disease will suppress to less than 50%. So here's the suppression is 100%, really good suppression, high-dose Dex. This confirms Cushing's disease, pituitary-dependent Cushing's disease, okay? However, you find that some ectopics also suppress, and therefore they get it wrong. So these 5 ectopic lung cancers will be told they've got Cushing's disease, and that's because probably it's carcinoid and they have a well-differentiated tumor, and so that's an error. But even worse than that, some ectopics do suppress, okay, and therefore it's not Cushing's disease, and similarly pituitary patients, 11 of them fail to suppress. So if you fail to suppress, it's 50-50 as to whether you have ectopic ACTH or Cushing's disease. And since just guessing will get it right 90% of the time, in other words, the probability of any Cushing's patients having pituitary Cushing's is 90%. Since the test is only 80% accurate, there's no point doing it. We might as well guess. So the high dose expression test has got to be abandoned, as now has been abandoned, and certainly from 2008, the endocrine Bible that we use, that most of the country uses, says this is of historical interest only because the prior probability is better than the test. The test misleads you more often than it helps you. So on that note, we'll move on to a bit more of what we do, which is, if you want to find the source, you need to undertake the technique that Dr. Walls mentioned earlier, which is pituitary sinus sampling, and you measure the ACTH from pituitary to check that it's not ectopic ACTH. And if it's not ectopic ACTH, you'll get a rise in the ACTH when you inject CRH, as we saw earlier. But what you mustn't do is use IPS to diagnose Cushing's disease, because you need to know for sure they've got Cushing's before you move to this step, because this step is saying, where is it, not have they got it? And that's an error that happens a lot, because here are some healthy volunteers. Again, only in the US can you do this. So healthy volunteers do an IPSS, and you basically find that they have a corticotroph secretion source, because that's where it comes from. The pituitary is the source. So healthy people, normal obese people, will have a high level of it, and you will therefore diagnose pituitary disease. So you have to know they've got it and want to go for surgery before you do this test. And all it tells you is, should you go for the pituitary or another part of the body? Okay, I'm going to stop sharing and let Dr. Henry tell you about her case.
Thanks very much, Prof. Miran. I'm going to start sharing my my screen now. Good, thanks for that introduction. So this is the case of a patient who was referred to us by a slightly unusual mechanism. Our colleague, Dr. Florian Wernig, was at Hammersmith Hospital one day, and another colleague stopped him in the corridor and said, "Florian, I'm really worried about my sister-in-law, and I think she might have an endocrine problem. I'd be really grateful if you could see her." So a couple of days later, an endocrine consultation was arranged. So this lady came to clinic. She's 34 years old and had a very a quick history of feeling unwell, previously completely healthy. But she spoke of gaining a great deal of weight over the last few months. She'd developed facial hirsutism and acne. She'd lost her periods. She was bruising very easily. She'd had lots of UTIs, and she was extremely low and anxious. And she'd gone to see the GP, who'd started an antidepressant. On examination, she was very tearful. Her mood was extremely labile. And in fact, I remember this consultation really vividly, because when I invited her into the clinic room, she sat down on my chair at my computer and was actually a little bit disorientated. And so I had to sort of quite nicely ask her if she would move into another chair. And this led to many more tears and lots of emotions surrounding that. She clearly had a round face. She was hirsute. She had abdominal obesity, but no stretch marks. Her skin wasn't particularly thin. She'd been bruised from having phlebotomy the previous week. She was strong in her shoulder and hip girdle, and she was not hypertensive. So I did bloods that day that she was seen in clinic, and I checked the cortisol at 4 o'clock. And as you heard from Prof. Miran and Dr. Walls, cortisol follows a diurnal rhythm of secretion. So if you do a cortisol at 4 o'clock, you'd expect something in the region of maybe 100 or 200. Sometimes, in fact, it's even in double figures. And so we have to be a bit careful, because our endocrine clinics are all afternoon clinics. And sometimes when you send an afternoon cortisol on someone just because you are doing that, the number can be quite low, and the poor medical registrar gets rung in the middle of the night saying this person's cortisol is 80, you need to give them a call. But in fact, that's just our misstep in doing a cortisol late in the day. So she had clearly a very, very raised cortisol. The ACTH was also up. She had a low potassium, and the sodium was at the upper limit of normal. So within 4 days, she was having an overnight dexamethasone suppression test. And as has already been covered, the rationale here is that if you give exogenous steroids, you should be able to suppress endogenous steroid production if somebody is physiologically normal. So she takes the tablet at midnight. She comes for blood tests the next day. She has a 9 a.m. cortisol checked, and it's really high. It's 750, and it should in normal physiology suppressed to less than 50 when you've taken dexamethasone at midnight, and the ACTH was also not suppressed. So she went on to have a low-dose dexamethasone suppression test, so that means taking 0.5 milligrams of dexamethasone every 6 hours over a 48-hour period. And again, at 48 hours, the cortisol was not suppressed despite taking all that exogenous steroid, and the ACTH remained high. So I think it's quite clear at this point that she has cortisol excess, but the fact that the ACTH is also high would suggest that this is ACTH-driven Cushing's rather than an adrenal source of glucocorticoid. So we went on to image the pituitary, and I just point out that it was really important to have done those biochemical tests first, because if you have a patient with cortisol excess and you go straight to the imaging, in at least 10% of people, and actually that's probably a conservative estimate, there will be what we call a pituitary incidental, so something that looks like a microadenoma, but in fact is of absolutely no significance and no consequence to that person. So this lady had a pituitary MRI, and what we found, as shown here, was a completely normal gland. There wasn't anything to see on any of the cuts. So we went on to perform what's called a dynamic MRI of the pituitary, and the rationale here is that if you give a bolus injection of contrast, there's very rapid uptake in the normal pituitary tissue. So this leads to a lot of enhancement of the normal pituitary, and a microadenoma, if present in the pituitary, can appear relatively dark. And after all that build-up, she actually had a normal scan. So the question is, what do we do next? So this is now 12 days after she's first been seen in our clinic, and she has really florid Cushing's. I mentioned that she was quite psychiatrically unstable, and this was actually progressing now very quickly. The biochemistry has shown she's got an ACTH-dependent Cushing's, but of course, as has been mentioned by Prof. Miran and Dr. Walls, you've got to be very clear about where that ACTH is coming from. Is it coming from the pituitary, or is it coming from an ectopic source somewhere else in the body? So she went on to have this technique, which has been mentioned earlier, which is inferior Petrosal sinus sampling, and this is done in interventional radiology over at the Hammersmith. I think, as Prof. Miran's pointed out, this is a really, it's a difficult technique. It's a highly specialized technique and really should only be undertaken in a very high volume center such as this one. And what this lady had was she had catheterization of the inferior petronal sinuses from where the blood from the pituitary drains, and peripheral blood samples are almost also taken at the same time. And the way that you interpret it, as has been discussed before, is you are looking for a gradient between the ACTH coming straight out of the pituitary into the petrosal sinus and the ACTH taken from a peripheral vein. And if you're going to diagnose ectopic ACTH, you want to see that the ACTH coming straight from the pituitary is 2 times as high as that taken from the peripheral vein, and you can see from these results that's not the case. So the amount of ACTH in the peripheral vein is actually largely similar to the ACTH being sampled in the petrosal sinuses. So this led us to conclude that this lady had an ectopic source of ACTH driving her cortisol excess. This then begins the hunt for the source of ectopic ACTH. During this time, she was becoming clinically much worse. She was having anxiety attacks, insomnia, the depression was absolutely terrible. So we started her on metyrapone and then ketoconazole, and both of these drugs inhibit adrenal cortisol production. This is just a holding mechanism. This is a way of trying to keep her clinically well while we carry on with the investigations. So at day 31, she had a CT, and this covered the neck, the thorax, the abdomen, and the pelvis, and it was normal. There was no evidence of any ectopic source at all for the ACTH. She went on to have a PET scan, and what you can see here is a hot FDG-avid brain. And when we took this to our MDT meeting, it was felt that there could be a lesion in the left lung, in the lower lobe, might be 6 millimeters or so, but it was definitely below the resolution of the PET scan. So the plan was to do a gallium scan to see if this lesion in the left lung was something or nothing. So she went on to have a gallium scan, and here is a cut very low down in the left lung, and where the blue arrow is pointing, that could be the nodule that was seen on the PET scan, and that's here in black and white, perhaps actually a little bit clearer. And this was discussed at great length in our MDT meeting. But there was a camp that said, yes, that probably is something, and another camp that said, actually, the proximity of the nodule to the surface of the spleen has probably led to some misregistration. And actually, what we're seeing there with the blue arrow is artifactual. That is not your source of ACTH. So what to do? We've got this unwell patient. She has a really high cortisol level, and clinically she's really suffering and needs treatment. So we discussed this with cardiothoracics, and here was the question: is the nodule really there? And if it is there, could this be a source of the ACTH? To which the conclusion was yes, and yes. So 74 days after first referral to us, this patient underwent surgical resection of that pulmonary nodule. And I, as a physician, as somebody who obviously doesn't do this, I find this description really lovely, because John Anderson, the surgeon who carried out the procedure, he actually felt between his fingers that nodule, and he knew that if he let it go, it would be pretty hard to find it again. So he had this lovely quote: "I felt it and I couldn't let it go." And happily, he didn't let it go, and he got it out. The nodule went off for histology, and it stained very intensely for ACTH. So the final diagnosis was bronchial carcinoma tumor secreting ACTH, and here's the slide for interest. So what happened to her clinically? Well, it's almost like magic. She has the source of ectopic ACTH removed. 4 days later, she has an undetectable plasma cortisol, and her ACTH levels are undetectable. What's probably the most important of all of that is she is feeling absolutely fantastic. So all of the psychiatric manifestation just disappeared, and she felt absolutely great. So just to say that very often after any curative surgery for Cushing's, be it pituitary Cushing's, adrenal Cushing's, or ectopic Cushing's, patients will often require a period of glucocorticoid replacement until the HPA axis recovers. So she, as you can see, had a very low cortisol, and she required hydrocortisone replacement for a year after the operation before this was successfully weaned. So 6 years on, she is a normal weight. Her mood is fantastic. She's had another baby. Intermittently, we follow her up by checking that her salivary cortisol at night remains normal, and it has to date, as you would expect with that clinical picture of feeling great and having no symptoms. And here's just a little bit of epilogue for you, that the same discussion, the same colleague once again bumped into Dr. Vernig with the comment, "I think you need to see my father-in-law." So maybe there's a lesson there for Dr. Vernig in terms of keeping his head down in the Hammersmith corridors. So just a few sort of closing thoughts with regards to this case. As Prof. Miran and Dr. Walls have really clearly pointed out, diagnosis of Cushing's is really, really challenging. And as Prof. Miran has shown, I mean, everybody is obese today. So it's more common in the UK to be either overweight or obese than to be a normal weight. So if you screen every single person who is not a normal weight for Cushing's, you'll end up with a lot of normal people having interventions they don't need. So really you need to have a very high pre-test probability of Cushing's before you go on to investigate somebody. It's really important to get the biochemistry in Cushing's sorted out before imaging, because otherwise the imaging can lead to you finding a lesion in the pituitary or a lesion in the adrenals that is absolutely no consequence and isn't contributing to the clinical picture. So in terms of this case, ectopic ACTH dependent Cushing's is a really rare subtype of a really rare endocrinopathy. If somebody does have ectopic ACTH, bronchial carcinoma tumors, as in this case, probably account for 20% of cases of ectopic ACTH. I think with this lady, the source of ectopic ACTH wasn't clear, and and something that maybe one discussion could have considered to be radiologically insignificant, in fact, turned out to be highly significant for her. So I guess the message is we all have to talk to each other, radiologists, talk to colleagues in other specialties, like getting the opinion from cardiothoracics. And as ever with all these things, an MDT collegiate approach wins the day. So back over to you, Prof. Miriam.
Thank you very much. So this is my last slide. Thank you, Sarah. That was very clear. So it's difficult, okay? And my summary really is a truly accurate diagnostic test for Cushing's is really yet to be discovered. Really beware of labeling normal obese people as Cushingoid. And don't just say, oh, let's just send off the blood test just in case, because that's not a good reason to screen, and you will get false positives, which can cause harm, as happened in case number 2. The high-dose suppression test should be confined to the bin, okay? So if you hear of it in the future, you should be able to defend not doing it. And imaging should only be performed once the endocrine diagnosis has been fully confirmed and be used only to find the lesion that you know is already there, rather than to say, have they got a lesion? Okay, thank you all very much. And if anyone's got any questions, please feel free to put them in the chat, or even unmute yourselves if you want. Thank you. Any questions? Let me get the chat up here. Yes. Oh, please. Got it. Hi, Ed.
Hi, so that was terrific. Thank you very, very much indeed. Can I ask, how many times do you end up with definitely pituitary-driven Cushing's, but with a normal, absolutely anatomically normal pituitary? And what do the surgeons then do? That's my first question. And obviously I have to ask you a lung question, but most surgeons would have wanted that nodule marking radiologically, either with barium or with a suture first, because they can be an absolute devil to find. And I know John's a terrific surgeon, but was that discussed?
It wasn't at their MDT, and they didn't go for that though in the end. With regard to your first question, can you hear me? Yes. With regard to your first question, so you're right, about half of our pituitary Cushing's patients have a normal MRI on pituitary. And our neurosurgeons have got very, very good. They've got scopes and things that can see around corners, and they actually identify the tumor at the time of surgery and only remove the tumor and leave behind the normal pituitary gland. So that is important.
I am here, Kareem.
Ah, Nigel, yes.
Yeah.
Go on then.
Well, a normal, Kareem makes it sound easier than it really is, because if you've got a negative MRI, a negative scan in about 30–40% of patients, you end up essentially exploring the gland. And it's very difficult intraoperatively to define whether you've actually found the tumor, which will be less than 1 millimeter, and often any abnormal tissue goes down the sucker. So with some of the normal MRI, the chance of remission is about 50%. If you've got a definite adenoma, it's up to about 80% long-term remission. But it leaves us with a bit of a dilemma. So I'll always consent patients to an early second operation, because if you do an exploration and don't find the tumor, then you have an option to go back in again within a week or so to resect part of the gland, to do a hemihypophysectomy, depending on where you think the lesion is likely to be based on IPPS. The problem about IPPS, that's not accurate either. They'll give false lateralizing size in about 30% of patients. And then the option is to then take out the whole pituitary gland, which is not something I would favor.
It is something that's done wrongly at other centres, though. I mean, I'm not trying to blow your trumpet, Nigel and Ramesh, but actually our cure rates have got very, very good because of your experience. I mean, I have no doubt about that. We have much less hyperpituitary than we used to or other sites do. And I think that's really important. As you say, the IPSS is not lateralizing. It's, as I'm keen to point out, is only to exclude ectopic ACTH, not to say which side it's from.
I think I would remind you, one of my first cases I did here was a Cushing's. I took out the yttrium implants.
Yes.
which I kept in my desk.
Yes.
I don't think health and safety would allow that now.
But there must be a normal range for ACTH in when you're sampling. So there must be a physiological secretion, and if you go, you know, log order over that, that surely must give you a clue that you've actually got pituitary secretion.
I think the problem is, so we do that for parathyroid tumors. The endocrine surgeons take a parathyroid, they measure intraoperative PTH. But ACTH is very spiky. So if you pulsatile, so if you do it 10 times, you get very, very variable results. And so it's not at all useful perioperatively. You really got to be at an extreme stimulus or suppression. Okay. It's 1:30. Thank you all very much. I hope you found that interesting, entertaining, and we'll see you next week for the Housing Staff round, which I think is being chaired by Liz Lightstone. Thank you.